Hello everyone, I'm Madeline Chamberlain, and with me today I have Catherine Jenkins. She is a APRN MSN FNP-C here at Rocky Mountain Allergy, which is a part of Tanner Clinic, which is like a great big umbrella clinic, lots of different specialty clinics within it here in Layton, Utah. She also contracts with a residential treatment center, and she has been a nurse practitioner for 5 years. So Catherine, if you can think back to when you first started practicing as a nurse practitioner, what was one or two of the biggest struggles you faced as you transitioned from an RN to a nurse practitioner?
I think one of the biggest things is just that as an RN, you always default to a physician, right? Mm-hmm. Whether you have standing orders for something or you're working on the written orders from a physician of some kind, you always kind of default back to them to answer any questions you have or if anything goes wrong. And when you're the provider, you're the one now who is answering all of those questions and then just kind of figuring out, you do your SOAP notes, right? And have all your assessment piece and coming up with a plan, but you've got to make sure that it's all implemented. And then within that, you suddenly go from working as the RN and having someone over you to being the person that's over the staff underneath you and having to kind of manage all of that in addition to your new role as an NP. It can be kind of an overwhelming process to make that transition. For the most part, like throughout your schooling, you kind of get that under your belt as you've done several hundred or thousands of hours of clinical rotations. But it is kind of taking one hat off and putting another on and it's a lot more responsibility. There's a lot more that is as expected of you as it should be, but it can be, for some people, it's a lot of pressure and it's a difficult transition. And then learning curve is huge. It's a big learning curve. I personally think that going from an RN to an FNP or an NP of any kind is nice because if you've had years of experience as an RN, it does make that transition easier, but the learning curve the first few years can be pretty steep depending on where you work and what you do.
Awesome. So consider your scope of practice and regulatory bodies within your state, and do you agree with the regulations of your licensure designated by the state, or are there any changes to credentialing or clinical privileges you would make?
The only really big thing, and we've kind of worked with legislature to get this changed, and it's still an ongoing process with the Utah Nurse Practitioners, and then as a group, there's a group that's called UNP, and then just as nurse practitioners throughout the state. But even when I was in school, I went up to the day at the legislature, but it's just the physician oversight. We're really trying hard to get rid of that. I do think it has its place in a few types of circumstances, but in general, we're for the most part really well trained, and to have that physician oversight agreement, I think is something that really needs to be gotten rid of, especially because NPs can open their own practices and have autonomy that way, and to have this paper, like a legal document saying that there's someone who would back you up most of the time. Those people are just getting paid an amount of money to do not a lot and not always would go and stick their neck out for the NP. Does that make sense? Mm-hmm. Credentialing wise, I just think that for the most part, if we're doing the same job, that we should be getting paid the same as physicians. I think that physicians, NPs, and PAs, if we're all in the same practice and we are all doing the same thing, we should be getting paid the same amount. Now, if there's a physician that's doing surgery and there's, a mid-level, that term, that is, being a first assist or not even in surgery, they're doing follow-ups, then that is understandable. But within a clinic setting, if we're basically doing and seeing and participating in the same thing, we should get paid the same. And I know a lot of times they'll bill incident 2 and have the physician kind of assume the charges for that, and I wish that would be different in some instances. Personally here, there's really not a whole lot that I don't do that the physician that we work with does. Some of that is just by personal preference, but if, for the most part, we do the same things. I have, a lot of autonomy, and I'm able to practice basically, independently and have the privileges that I want here, which is really great.
Awesome. So do you consider yourself working in a collaborative practice? I think you've kind of touched on this a little bit, but like how often do you collaborate with the other providers you work with, and can you provide a scenario where you consulted with another provider for a patient?
So because we work at Tanner Clinic and there are multiple clinics within our big umbrella of a clinic, we do have a really great opportunity to collaborate with other practices. So actually down the hall we have pulmonology, we also have ENT. So within our specialty practice, me, the physician, and the PA, we will often collaborate with each other. If we have questions on a patient or we're kind of running a case through our minds, we will talk to each other. But like as far as interdisciplinary collaboration, yes, we will often, just walk down the hall, pop the other way and ask them same thing about a patient. It's really, really nice because I've worked in places before where it's been all phone work where you have to pick it up and try to get through to someone. Mm-hmm. For the most part, I feel like nowadays people are really amenable to kind of what we call the curbside consult, where you can pick up a phone and call someone in Durham and say, hey, we had this happen a few weeks ago. We had someone we thought had something kind of rare. So we picked up the phone, called upstairs to our Durham office, said this is what we thought was going on. They got the patient right in and we were able to kind of work together to manage that. Same thing happens mostly with Pulm and ENT. Those are the two for the most part that we collaborate with a lot, but we do have the opportunity to do that with them, and we just kind of can walk to their office or pull them aside and kind of co-manage patients, which I feel like really helps us as providers and the patient in getting the healthcare that they need, and that we need them to receive, so that everybody's kind of on the same page. And you really do get better healthcare when you can do that. And then also we have a lot of PCPs, whether they're pediatrician, internal medicine, or family practice, that will often call us or come up to us and ask us questions about patients, mostly with food allergies, but we do collaborate with them, and it just makes it a lot nicer, because I have worked in places as an RN where there was no collaboration there. It makes it difficult.
Mm-hmm. Great. How do you measure or evaluate success in your job as a nurse practitioner?
I don't know, it's kind of hard to evaluate your own success. I mean, I've been in the same job for 5 years. I feel like I have quite a large patient population that comes back to see me regularly, and I feel like if I've seen somebody and obviously if they liked the healthcare that they received, not just like my personality, but they felt like their symptoms were managed and controlled, they were listened to, then when they come back in 6 months, there's 3 of us here that they can make appointments with. And I get that a lot of times just your calendar and availability drives what appointments you make. But I have quite a high volume of patients, I think, that come and see me regularly on my schedule, which also says something because I work part-time. So the fact that they're willing to fit what they need into the schedule that I work, because my availability is only half a week, that to me says that I must be doing something right if their healthcare continues to be managed and they are wanting to come back and see me. I feel like that means I must be doing a good job doing something.
Definitely. So. And what recommendations do you have for nurse practitioner students or nurse practitioners newly entering the field of practice?
I just think get as much experience as you can, wherever you can, and jump right in with both feet. It can be a huge learning curve. Again, mostly just because a job like this, you can only learn so much through textbook. You really have to have the hands-on experience. And in medicine in general, it doesn't really matter your role, but of course, the more responsibility you have to care for a patient, the higher that responsibility is, right? And I just think new NPs, a lot of times they get scared or intimidated. I know some they have been pretty picky about jobs, which is good and bad. You kind of need to just get in there and see how the field is itself, and then you can kind of change from there. But really, it's just understanding that it's going to be a bit, but having people you can ask questions is kind of the other thing. So whether that's your other classmates who are maybe in different fields, I went to a family nurse practitioner program, but I work in a specialty clinic. I have, in my cohort, there were, I think, 13 of us that graduated, and I still have at least a handful of those people that work in different avenues, that on the occasion I need to curbside consult someone outside of Tanner Clinic. I can, and I have before, and that's really great to kind of know when to reach out and ask for help. And I guess maybe that's my biggest message, is that you're new and you're learning and it's okay to ask questions, you should ask questions, and that is fine. You're gonna learn more the more you're exposed to different types of things. The more questions you ask, the more you learn and the more you apply. I think, the better that you'll do. And don't be intimidated. Everybody is nervous. Like, I don't know, I'm not one to be easily intimidated, and I was thrown into some super hairy clinical rotations throughout school and then kind of jumped in with both feet when I came to this job. I trained the least amount that a peer NP has trained in this clinic, and then I only trained for a couple months, and then I had a baby for 3 months, and then I came back and got a full caseload, and you just gotta do it. At some point, you just have to take the leap, but just make sure that because you are responsible for so much more, your prescriptive practice and patient outcomes, just be sure you know what you're doing, and if you have questions, ask.
Awesome. Well, thank you for participating.
You're welcome.